Chapter 12, Diagnostic Coding. Objectives for Lesson 12 is 1. Explain the reasons for and the importance of coding diagnoses. 2. Describe the importance of matching the correct diagnostic code to the appropriate procedural code. 3. Differentiate between primary, which is the first listed, principal, and secondary diagnoses as discussed in meeting diagnoses. 4. Describe how medical necessity is supported by the diagnosis code. And 5. Discuss the history of diagnostic coding. 6. Discuss the benefits of the ICD-10 coding system and differentiate between ICD-10-CM and ICD-10-PCS. 7. Identify and describe the alphabetic and tabular index of the ICD-10-CM coding manual. 8. Define and demonstrate an understanding of diagnostic code conventions, symbols, and terminology. And 9. Apply general coding guidelines to translate written descriptions of conditions into diagnostic codes. 10. Apply chapter-specific coding guidelines to reporting of specific illnesses and conditions. 11. Relate additional coding guidelines specific to the reporting of outpatient services. 12. Describe methods of becoming more familiar with codes commonly encountered in a specific healthcare organization and discuss computer-assisted coding. And 13. Anticipate future changes to the diagnosis coding system known as ICD-11. Diagnosis coding for outpatient professional services. The guideline for diagnostic coding must be followed when assigning codes. Only diagnoses that currently relate to the patient's state should be coded. Payment for services may be tied into diagnostic coding due to medical necessity requirements. A coder must know the current diagnostic coding guidelines, medical terminology, anatomy and physiology, clinical disease processes, and pharmacology. Assigning a diagnosis code. Diagnostic coding must be accurate because payment for inpatient services rendered to a patient may be based on the diagnosis. In the outpatient setting, the diagnosis code must correspond to the treatment or services rendered to the patient, or payment may be denied. Do not code conditions that relate to a previous medical problem if the conditions have no bearing on the patient's present condition. Sequencing of diagnostic codes. The primary diagnosis, which is the first listed, is related to the chief complaint and is the main reason for the encounter. A secondary diagnosis may contribute to the primary diagnosis, not the underlying cause, which is etiology. And then your principal diagnoses are only applicable to inpatient cases and claims. It is similar to the primary diagnosis for outpatients. Now, your primary and secondary diagnoses are used for outpatient visits only. A principal diagnosis, again, is used for inpatient encounters. And an etiology is the cause of the disease, the study of the cause of the disease. Admitting diagnosis. The inpatient admission diagnosis may be expressed as one of the following. 1 or more significant findings representing patient distress or abnormal findings on examination. A diagnosis established on an ambulatory care basis or previous hospital admission. An injury or poisoning. Or a reason or condition not classifiable as an illness or injury, such as pregnancy, in labor, or follow-up inpatient diagnostic tests. When a physician makes hospital visits, you code the reason for the visit, which might not necessarily be the reason the patient was admitted to the hospital. Medical necessity. Insurance companies may not cover procedures that are not diagnosis related. Your reference book is helpful in these situations. For cases dealing with the Centers of Medicare and Medicaid Services, the CMS, you consult the Regional Fiscal Intermediaries website for local coverage determination, the LCDs, or also consult the federal government's website for national coverage determinations, the NCDs. Procedures that are diagnosis related include most imaging services, such as cardiovascular services, neurologic services, and many laboratory services, and vitamin B12 injections. International Classification of Disease History. ICD began in England during the 17th century. The first official version was in 1948. United States started using ICDs in 1950. The 8th revision of ICD, ICD-A-8 in 1966. The 9th revision of ICD, which is the ICD-10-CM in 1979. 10th revision of ICD, which is the ICD-10-CM in 1992, but was not implemented in the United States until October 1st of 2014. Transition from ICD-9-CM to ICD-10-CM. The insurance specialist must be familiar with both ICD-9-CMs and ICD-10-CM. The date of service will determine which coding system to use. Non-covered entities are not required to implement ICD-10s. The process of locating a diagnosis code is the same in both coding systems. Coding systems are organized similarly. Your alphabetic index is used for locating main terms, and your tabular index to verify the selected code. Both coding systems have a neoplasm table and a table of drugs and chemicals, including in the alphabetical index. The ICD-10-CM allows more code choices and requires greater documentation in the medical record. The appropriate conventions and official coding guidelines for these specific coding systems, the ICD-9-CM versus the ICD-10-CM, is being used should be referenced at any time codes are selected to ensure accurate reporting. The ICD-10-CM exceeds previous systems, such as the number of concepts and codes provided, expanded to include health-related conditions, and provides greater specificities, reporting to the 6-digit level with 7-digit characters. The crosswalks were created to facilitate the coding process between ICD-9-CMs and ICD-10-CM. The general equivalence mappings are called GEMs are used. GEMs can be used to translate codes accurately and effectively. Mapping from ICD-9 to ICD-10 forward mapping, and mapping from the ICD-10 to ICD-9 backward mapping. Many software vendors have used GEMs to create crosswalk publications and software that are available and will facilitate cross-referencing between the two coding systems. GEMs is the common translation tool developed by CMS and the Centers of Disease Control and Prevention, the CDC. ICD-10 diagnosis and procedure codes. The benefits to adoption of ICD-10 is its much greater specificity, which includes laterality and ordinality of encounter. The expansion of clinical information, which reduce cross-referencing. The flexibility and easy of expandability. The updated medical terminology and classification of diseases. The ability to compare mortality and morbidity rates, and fewer non-specific codes than in the ICD-9-CM. ICD-10-CM meets HIPAA criteria by providing specific information for outpatient and inpatient procedures, describing medical services using terminology in today's environment, expanding injuries and disease codes and categories, and giving a more precise, clear, and clinical picture of the patient. The ICD-10-CM and ICD-10-PCS. The ICD coding manuals consist of two different types. You've got your International Classification of Diseases, 10th Revision, Clinical Modifications, the ICD-10-CM, which are used for diagnosis coding for office and outpatient services. The International Classification Disease, the 10th Revision, Procedure Coding System, the ICD-10-PCS, is used for coding of procedures for inpatient services. Diagnosis coding for outpatient services provided prior to October 1st of 2014 was in the International Classification of Diseases, 9th Revision, Clinical Modification, the ICD-9-CM, Volumes 1 and 2. Organization and format of the ICD-10-CM. The ICD-10-CM manual is updated annually. It contains a tabular list of diseases, contains an alphabetical index to disease and injuries. The annual updates of the ICD-10-CM are published in 3 publications, and the annual updates must be in place and in use by October 1st each year. The 3 publications in which the annual updates of the ICD-10-CM are published are the Coding Clinic, published by the American Hospital Association, AHA, the American Health Information Management Association Journal, which is published by American Health Information Management Association, AHIMA, and the Federal Register, which is published by the U.S. Government Printing Office. The Alphabetical Index to Disease and Injuries. It contains the table of drugs and chemicals, the neoplasm table, and index to external causes. The main code descriptor items are in alphabetical order. Indented are the subterms, and applicable additional qualifiers, descriptors, or modifiers are beneath the main terms. Special points to remember in the alphabetic index. The appropriate sites or modifiers are listed in the alphabetical order under the main terms. Examine all non-essential modifiers. Eponyms appear as both main term entries and modifier under main terms. Look for sub-listed terms in the parentheses associated with eponyms. And locate closely the related terms, code categories, and cross-reference synonyms. The tabular list of disease and injuries. The ICD-10-CMs are composed of alphanumeric codes that represent the diagnosis. The ICD-10-CM codes contain up to 7 characters with a decimal point after the 3rd character. The first 3 characters are placed to the left of the decimal point will indicate the category. The remaining digits to the right of the decimal point will indicate the etiology, the anatomical site, and the severity. Digit number 1 would be your alpha character. Digit 2 and 3 are numeric characters, and digits 4 to 7 are alpha or numeric characters. The 6th character can signify laterality. The intent of a drug poisoning is intentional self-harm, assault, etc., with or without a given manifestation. The trimester of a pregnancy, the depth of a skin ulcer, or the nature of an injury. The letter X is used as a placeholder. It will save space for future code expansion, and it meets requirements of coding to the highest level of specificity. Special points to remember in the tabular list. Some special points would be: use 2 more codes when necessary. Search for 1 code when 2 diagnoses or a diagnosis with an associated secondary process or complication is present. Use category codes only if there are no subcategory codes. And read all instructional notes provided. Diagnostic Code Book Conventions. The conventions would be the abbreviations, punctuation, and symbols, placeholder character, seventh characters, other and unspecified codes, includes notes, excludes notes, the default code, gender and age codes, and selection of a coding manual. General coding guidelines. When locating a code in the ICD-10-CM, you want to first locate the term in the alphabetical index. Then verify the term in the tabular list. And then the dash at the end of the alphabetical index entry indicates that additional character is required. This will be determined by the tabular list. Even if a dash is not present, it is necessary to always refer to the tabular list to refer to all additional instructional notes. You never ever want to code from the index. The level of detail in coding. The ICD-10-CM codes are composed of 3, 4, 5, 6, or 7 characters. And you always want to code to the highest level of specificity. A code is invalid if it has not been coded to the full number of the characters required for that condition. You can only code the signs and symptoms if no precise diagnosis can be made, the signs and symptoms are transient and a specific diagnosis was not made, provisional diagnosis for a patient who does not return for further care, or a patient is referred for treatment before a definite diagnosis is made. The guidelines for coding signs and symptoms are different in the hospital health information management departments. Conditions that are an integral part of the disease process, so the signs and symptoms should not be assigned as additional codes. Conditions that are not an integral part of a disease process, so the signs and symptoms should be reported when documented. Multiple coding for a single condition, use additional code and code first. While use additional code notes from the tabular list will guide the coder as to when it is appropriate to report a secondary code. When the code is to be sequenced first in the determined, the additional code will be reported as secondary code. Code first notes are also indicated in the tabular list and are typically used to identify an underlying condition. The underlying condition is always reported as the primary code. Acute, subacute, and chronic conditions. Code acute or subacute sequence first, followed by the chronic condition code. The combination code is a single code used to classify two diagnoses, or a diagnosis with an associated secondary process such as a manifestation, or a diagnosis with an associated complication. Identify a combination code by referring to the subterm entries in the alphabetical index and by reading the inclusion and exclusion notes in the tabular list. If the condition of a combination does not specifically describe the manifestation or complication, use a secondary code. There is no time limit on when a late effect code can be used. Coding of a sequela generally requires two codes. The nature of the sequela is sequenced first. The sequela code is sequenced second. If there is no subterm under impending or threatened for the condition described, report the existing underlying condition. Reporting the same diagnosis more than once. Each diagnosis code may be reported only once for an encounter. Laterality is the final character of the code to reflect the laterality. The right side is always character 1, and the left side is always character 2. In those situations, when a bilateral code is given, the bilateral character is always 3. If the side is not identified, an unspecified code is provided, which is either a character 0 or 9, depending on whether it is a 5th or 6th-digit character. Documentation for body mass index, the BMI, and pressure ulcer stages. The patient's provider must document the associated diagnosis as either obesity, pressure ulcer, etc. Syndromes will show a symptom complexity reported by following the alphabetical index. Documentation of complications of care is assigned based on the provider's documentation of the relationship between the condition and the care of the procedure. Chapter-specific coding guidelines. In addition to the general diagnosis coding guidelines, there are guidelines specific to the 21 chapters of the tabular index. Some of the most frequently referenced chapter-specific coding guidelines are provided in this text. However, the insurance billing specialist must be familiar with the entire contents of the official coding guidelines and refer to them when reporting on all conditions. The chapter-specific guidelines are located in Section 1, Subsection C of the official coding guidelines. And these are some of your chapter-specific coding guidelines for human immunodeficiency virus, HIV, neoplasms, coding of diabetes mellitus, circulatory system conditions, hypertension, myocardial infarctions, pregnancy, delivery, or abortion. Injury, poisoning, and other consequences of external causes, the injuries and late effects, burns and corrosions, adverse effects, poisoning, underdosing, and toxic effects, external causes of morbidity, factors influencing health status and contact with health services, encounters for reproductive services. Diagnostic coding and reporting guidelines for outpatient services. Section 4 of the official coding guidelines contains a set of rules specific to reporting of outpatient services with which the health insurance specialist should be familiar. The guidelines are approved for use for reporting of hospital-based outpatient services and provider-based office visits. The guidelines are used in conjunction with the general and disease-specific guidelines. Some of these guidelines are outpatient surgery and certain diagnoses, chronic disease, code all documented conditions that coexist, patients receiving diagnostic services only, preoperative evaluations, and general medical examinations with abnormal findings. Handy hints for diagnostic coding. And they are: identify important references with a highlighter. Add a table to main section of the alphabetical index, tabular list, and drug and chemical table. Keep a list of diagnostic and CPT procedure codes commonly encountered by your office. Consult payer guidelines. The AMA publishes a list of the most common diagnostic codes at the end of each of its many specialty code books. And some medical practices develop an encounter form that is an all-encompassing billing document. Computer-assisted coding. Many factors have pushed medical practices to adopt the computer-assisted coding, the CAC. The CAC is a computer software that automatically generates medical codes of review, validation, and used based on clinical documentation provided by healthcare practitioners. The two technology options are structured input, which is data entry screens with a point-and-click fields, pull-down menus, structured templates, or macros. The NLP is a natural language processing system that must be regularly updated to address new medical terminology and conform to changes in coding guidelines. The future of diagnosis coding. The ICD is constantly under revision. Development of the ICD-11 began in April of 2007. The ICD-11 is also alphanumeric. The ICD-11 builds a structure of ICD-10 and will be similar in appearance. ICD-11 will be a digital product that will link with terminologies and support electronic health records and information systems. ICD-11 was scheduled for dissemination by 2012, but the timeline has been pushed back and is expected to be unveiled to the world in May 2017. And this concludes the lecture of Chapter 12, Diagnostic Coding.